This forum on doctor-doctor communication. I'm Matt Ryan from the Department of Emergency Medicine, and this is our third forum that we are conducting as part of the Physicians I Promise Leadership Campaign.
I'm Father Alan Bauer. I'm the Catholic chaplain here at Shands Hospital, and I recognize many of you out there that see me going through the halls regularly. And what I wanted to share was I get a unique relationship because of my interaction with patients, and a lot of times they'll say to me what they probably won't say to you. And so I'm just going to give some things. I would say overall, first of all, generally we do an outstanding job. But there's always those things, and I'm just going to hear a few of the things that come up rather commonly in the course of a week. This is the most common one I hear is I'll ask them, what are the doctors saying? And it says, well, I saw 10 different doctors and I got 10 different opinions. And that really stresses them out. And I think maybe we may do too much theorizing. Well, it could be this, it could be that, but I try to always focus them getting back to the team leader, because I said one is in charge that will ultimately decide the direction your health care plan will be taken. The vast majority of patients, they appreciate straight talk. If you don't know, fine. And I always emphasize to them, I says, they just haven't figured it out yet. I say, we are blessed with doctors that are very persistent.
Dr. Elie, mine?
To do fellowship in critical care in trauma, in shock trauma in Baltimore. And I was fortunate enough afterwards to become junior faculty at another institution in the United States, which I won't mention. And and I couldn't have been more happy and proud that I was given the opportunity to do that. And of course, I'd be remiss if I hadn't mentioned that I'm a black woman in medicine. And quite frankly, being a black woman in medicine makes me a minority in two ways. And so I've had lots of challenges, I'll admit to that. I have at least half a dozen patients that have told me how proud they are that there's a black woman working as a physician, because they lived through the civil rights movement, and I am a validation of all of the struggles that not only they, but perhaps even their ancestors had gone through. And so there's great pride in my being black and being a woman in this field. Fast forwarding to when I became a junior faculty member, my first month there was very challenging and actually made me question why I had decided to go into medicine. And it was because I felt as if I had been in a time warp. And that's because one of the first interactions I had was with a physician who was not necessarily in agreement with a decision that I had made. The physician had come down and discharged a patient, and I had disagreed and felt that the patient was probably a little unstable and needed to stay in the hospital. And so the physician did return to the emergency department with his entire team in tow. 6 residents, 2 medical students, and a nurse. And I was called overhead to the bedside with the patient in the room. And I was asked to present the case and why I felt the patient needed to be in the hospital, which I did. And subsequent to my presentation, I was told that my opinion didn't count, that my input on the case was not considered appropriate, and that the patient would be discharged anyway. I was able to leave the institution with my reputation intact. But having said that, the interactions that I had made me question a lot of what I had grown to love about the profession, and a lot of what I felt should be reasons why I should be proud to be in the profession. Having said that, these are, again, rare circumstances. The vast majority of my circumstances have been positive ones. So I will end with a very positive experiences here. One of my first interactions in trauma, similar interaction to, or similar case to what I had experienced in my previous institution. An unstable patient had come in, and the trauma attending walked in right behind me and said, "What do you think we should do?" It was refreshing, to say the least. Thank you.
How do you think we can do better? Or first of all, do you agree? And then how do you think we can do better in our country?
I do agree, and I think it's fairly important for us to identify when there are situations which are considered sentinel events. when there is a physician interaction which is disruptive in the clinical environment, I think we tend to allow the physicians to work it out. But the reality is that we should all be involved, and we should all be engaged in what's generating that interaction. Is it an operational issue? Is there something going on that, or is it a personal issue? Is there something going on with that individual? And so I think leadership, and in particular when they identify that these interactions occur, need to address it immediately. And I think in my situation that didn't happen.
How do you figure out who the attending you need to talk to is? If we're on call at night and there's a patient in the emergency room and we need to communicate, we don't know who the emergency room attending is taking care of that patient. I now know what the number is for the PIC phone, but I don't know how to get a hold of you in Core 2.
Yeah, that's such basic information that
These are
everybody should
basic
have access
problems that need to be solved. We need to establish a better method of finding out who the responsible attending is so that we can have attending to attending communication.
You've got a good team, everybody gets along, and everybody values everybody else's contribution. And I think respect is the #1 thing that we all need to model for our residents.
Thank you guys, appreciate it.